So, hello everyone. I welcome you on behalf of IPA, myself, Dr. Bakul Parekh, the committee chair, and Dr. Abhay, the convener. We welcome you all to today's webinar. There is a third webinar on torch infections in neonates. And we have with us Dr. Tanu Singhal, who is going to moderate the session. And we have got excellent faculties in terms of Ida, Rima, and Aleja. So I'm sure you'll enjoy this academic feast over a period of next 1.5 hours. And we'll take your questions after the session is over, if the time permits. And in between, whatever questions you have, you can put it on your chat box or question answer session, and we'll try to answer almost all the questions. This webinar is getting really very popular. The way the message I received from our IPA president, Dr. Naveen Thakkar, and the IPA admin is doing a great job in organizing these webinars. So now over to Dr. Abhay to take it forward.
Yeah, so good morning, good afternoon, good evening, everybody. Welcome to this third IPA ID webinar, and that is on torch infection in the neonate. And one of the highlight of this webinar is that there is a complete representation of the woman empowerment, because it will be moderated by Dr. Tanu Singhal, and all the three expert speakers are also female. So it will be my great pleasure to introduce our moderator, Dr. Tanu Singhal. She has passed his MD Pediatrics from a very prestigious institute, that is Delhi. And then she has done her MSc Infectious Disease from the London School of Tropical Medicine, London, UK. Currently, she is working as an ID specialist at Kokilaben Dhirubhai Ambani Hospital, Mumbai. She has been an expert member for the pediatric tuberculosis NDP program, which is a very well-known program for the prevention and elimination of tuberculosis in the country. And she is also a board member for the Fungal Infection Study Forum. She has been awarded a prestigious Dr. I.C. Verma Excellence Award in the year 2020. Tuberculosis, antimicrobial resistance, vaccination, and COVID-19 are her special area of interest. And to her credit, she has 108 publication in PubMed Index journals. She has been on the editorial board of the 3 books, and she has contributed in 25 chapters in the different books. So it will be our pleasure and honor to have you, Dr. Tanu Singhal, as one of the most important moderator of this webinar. And in fact, to give one sentence introduction, Dr. Tanu Singhal said, whenever there is any difficulty in India about the infectious disease, we always look forward to her special comment. So over to you, Dr. Tanu Singhal. I request to you to introduce all the 3 experts as well. Over to you, madam. Yeah.
Thank you, Dr. Abhay Shah. May I please have the next slide, please? For the other panelists. Yes. So I actually did do a kind of a search for the other panelists, quick search I did on Google. So Dr. Reema Wakim is an associate professor of clinical pediatrics and pediatric infectious disease at the American University of Beirut. She completed her pediatric residency at SUNY Upstate Medical University and her fellowship in pediatric ID at Stanford University. She's board certified in pediatrics and pediatric ID. Her research focuses on antimicrobial resistance and primary immunodeficiency disorders. She is the co-director of the PID program and the director of the fellowship in PID program at American University of Beirut. And she's a member of the IDSA and the European Society of Immunodeficiencies. Next, please. Dr. Ida from Turkey. She is a faculty member in the Department of Pediatrics at Biruni University School of Medicine. She has been working in the field of pediatric infectious disease and providing training in this field since 2009. She previously worked at Marmara University Faculty of Medicine for 15 years and at the Basiri University, please forgive me if I'm not pronouncing it correctly, Faculty of Medicine for 1 year, and is experienced in vaccine preventable diseases, infection prevention, and treatment in immunocompromised patients, healthcare associated infections, and tuberculosis. She continues her career as a clinician, academician, and researcher. Welcome, Dr. Ida. Next, we have Dr. Alejandra Soriano from Costa Rica. She completed her medical training at the Universidad de Ciencias Médicas in Costa Rica. She then completed her residency and fellowship in pediatrics and pediatric ID at the University of Costa Rica. Afterwards, she did a postdoc research fellowship at the University of Texas, Southwestern Dallas, Texas. She has participated in multiple studies, published multiple indexed articles, and delivered at many international conferences. Welcome, Dr. Alejandra. So I think it's going to be an exciting evening for all of us. And with that introduction of all the panelists, I'm going to share my screen now. So today's discussion will be in the form of cases, and we have tried to cover most of the infections. And we know that this acronym TORCH, in which TRCH stands for Toxoplasmosis, Rubella, CMV, and HSV, and this O stands for others. And this others is a very expanding, thing where, you have varicella zoster, syphilis, HIV, HCV, HBV, HHV, enterovirus, parvovirus, Zika, TB, malaria, and the most recent addition has been Mpox, because Mpox is also transmitted from the mother to her unborn child. And this transmission may be antenatal, perinatal, or postnatal, and the consequences may be asymptomatic infection to abortion to stillbirths. And the diagnosis of these infections is challenging, and the manifestations often overlap. And there are treatment options available for some of these infections. And we will discuss some of these infections through illustrative cases. And the objective of today's session is not to discuss everything about torch infections, because that is not possible in the limited time that we have today. But we will try and discuss some of the salient features of some of these infections. Which brings me to the first case of today. And all these cases are from India, but I'm sure that everybody here who is in this audience will be able to connect to these cases. And they could be anywhere in the world. So this is a 35-year-old seventh gravida with 6 previous abortions. So this is like a bad obstetric history. And this current pregnancy, when she comes for her scan, which is at the 18-week scan, her ultrasound shows that she has hepatic and splenic calcifications, and the brain shows periventricular lucencies. And with this finding, obviously, the person suspects that there is a torch infection. So she undergoes an amniocentesis, which is sent for a PCR, and their CMV PCR is positive. So obviously a diagnosis of fetal CMV infection is made. And with this, I would like to ask Dr. Reema, like, very often, TOTS test is asked for a woman who has recurrent pregnancy loss. So can TORCH infections cause recurrent pregnancy loss? And do you think that in this lady, all her previous abortions were due to CMV? And now that we have diagnosed that she has fetal CMV infection, can we do something to improve the outcome in this patient? Dr. Reema, please.
Well, thank you very much, Dr. Singhal, for the questions and for the invitation to this interesting webinar. So recurrent pregnancy loss, or RPL, has been a major issue, in particular in the OBGYN literature, looking for what are the causes. And there has been several studies looking for infectious etiology leading to pregnancy loss, not RPR, one abortion or one miscarriage. So we know that CMV, Toxoplasma, Listeria, other infections might lead to pregnancy loss. However, there are no data that shows that recurrent pregnancy loss are related to one type of infection. So if a lady who is pregnant develops primary CMV infection or reactivation, that might explain one miscarriage or two miscarriages, but not several pregnancy losses, unless in the very rare instances where she has immunodeficiency, whether she has primary immunodeficiency or secondary immunodeficiency from HIV, then this is a different story. So for this particular lady and her 6 previous abortions, I do not think, frankly, that CMV contributed to the 6 previous pregnancy loss. However, with this pregnancy, what we're dealing with and with her, the evidence of CMV PCR, we need to deal with this current pregnancy. And of course, OBGYN needs to evaluate her for other etiologies of RPL, like if she's having clotting problems or genetic disorder leading to these pregnancy losses. Do we have information on her previous pregnancy loss? Do we have like pathology on the aborted fetuses?
No, we don't, but she was investigated for the other common causes like cardiolipin antibodies, lupus, and all those things, and none of those were found. So all the basic workup was done.
Okay, so now with her current pregnancy, she's now at which gestational week?
She's at 18 weeks.
So she's at 18 weeks. So the second question would be, are we dealing now with a lady who's having primary CMV infection, or is she having non-primary CMV infection? We do not know because we don't know her symptoms. Did she have any cold symptoms or non-specific symptoms?
Well, in India, most of the patients have reactivation because 99% of the women are already IgG positive when they become pregnant. So in most cases in India, it is basically reactivation disease.
Okay, and there is the rare, the other entity in the non-primary CMV infection. So we have either reactivation or we have reinfection with a different CMV strain. So in areas where we're in developing areas, like for instance, in Lebanon, in India, or other countries where we have overcrowding, women tend to have primary CMV infection early on, like during their teen years or their early adolescent or adult year before they get pregnant. So most likely we're having a pregnant lady who has CMV reactivation, and we have now a fetus who has congenital CMV infection at 22 weeks of gestation. Now, I think your second question was what are we going to give this woman for the congenital CMV in the fetus? Is that correct?
Yes.
So that's a tough question. There are, over the years, there have been, as you know, several modalities to treat women who have CMV infection, but not at this stage. So we established now that the fetus has congenital CMV. There are now data for women who have diagnosis of CMV infection early during pregnancy and where we do not have the status of the fetus. So in that category, there has been recent data about using valacyclovir, because from all the antivirals available to treat CMV, all of them have high level of teratogenicity. So for adults or immunocompromised patients, we tend to use valganciclovir, cytofovir, or foscarnet, and all of these are not options for a pregnant lady with CMV infection to protect the transmission to the fetus. So there has been a couple of European studies, and there are now ongoing studies about using valacyclovir, which there are a lot of studies on it for genital herpes in women. So they use valacyclovir at a very high dose, 8 grams per day divided in 2 to 4 doses. And the recommendations from the ACOG and the Royal College of Obstetricians is to use this in the setting of a trial, not haphazardly, just to monitor for two things: for toxicity in the mom, because at that high dose we risk kidney toxicity, and to monitor for another theoretical or possible side effects is the development of adaptive immunity in the mom. So if the mom has primary CMV infection and I'm giving her valacyclovir, I might prevent the development of appropriate adaptive immunity. There has been a couple of case reports where the future pregnancy after the first one had the worst outcome because the mom did not have appropriate maternal antibodies. So the options, if this was a primary CMV in the mom, and I don't know the status of the fetus, would have been using valacyclovir at a high dose if I'm early on during the first trimester, so below 14 weeks or within 8 weeks from the maternal infection. But right now, theoretically, she's around 22 weeks, so this is not an option. Other options for primary CMV infection where we don't have fetal infection yet, there have been studies on CMV hyperimmunoglobulin, so CMV hyper IgG for the mom, but also these studies were not very promising, and most people would not use them unless they are part of a clinical trial. So for this child, he's already 22 weeks gestational age, and we know that there has been already damage. So I do not think there are options to give to the mom as medication at this point because the damage has been done. The option to offer miscarriage might be difficult in some cultural context. So, for instance, in Lebanon, people do not like to do abortions. So this is tough. We can explain to the mom the risk of congenital CMV in this fetus and give her the options about either going on with her pregnancy or losing the baby early on.
I think you have exactly. So right now, because the baby is already infected, there's nothing we can do. And she would have to carry on her pregnancy. And coming back to this same patient, when the baby was born, the baby did have some features of congenital CMV. There was leukocytosis, the platelet count was low. There was hepatic and splenic calcification. The eye examination was normal. The hearing evaluation was normal. And the CMV IgM was negative, and it can be negative because IgM is not a very sensitive test. However, the blood CMV PCR was positive, the CSF was negative, and the MRI of the baby did show the periventricular lucencies, which though there was no calcification. So what quickly, Dr. Rima, how would you treat this baby? Does this baby merit antiviral treatment? He does not have hearing impairment, but he does have CNS involvement. So how would you treat this baby?
You know, this is again a tough call, and I'm going to talk about the recommendations, the international recommendations, in particular the recommendations from the AAP and from the CDC, and tell you also what is applied in our part of the world where you have financial constraint in using medications and in doing follow-ups. So we're dealing with a newborn who has now congenital CMV infection. We know that congenital CMV infection represent around 1% of all live births. Out of these 1%, 90% are asymptomatic and 10% are symptomatic, like this kid, like this patient. So in addition to the neuro manifestations, you might see hepatosplenomegaly, you might see also hearing impairment, CMV retinitis, they might have autoimmune hemolytic anemia, skin rashes. So this is in the 10% category of kids who are symptomatic. The 90% who are asymptomatic, they still have the virus latent, and this virus might replicate and has infections in the CNS mainly. The main concern in the asymptomatic kids are having hearing loss. Even if the hearing assessment at birth is normal, it might occur later on, and having neurodevelopmental delay and bad outcomes in terms of neurodevelopment. And the treatment is different for congenital CMV, whether we have life-threatening, symptomatic, or non-life-threatening. So for this kid, I know the brain MRI looks horrible, but you would consider this life-threatening. This might lead to seizures, but he does not have at this point CMV pneumonitis or CMV significant hepatosplenomegaly with pancytopenia, except maybe for some low platelets. So for this group of patients, there have been studies over the years to see what is the optimal treatment. So we can offer IV ganciclovir. The question is going to be, for how long are we going to give IV ganciclovir? There has been several studies over the last 30 years maybe, where they went from, for kids who have symptomatic, life-threatening congenital CMV, giving IV ganciclovir for a certain period of time, ensuring that they are stable, and then switching to PO valganciclovir for at least 6 months or more, depending on the clinical status on the CMV viremia also. What I would do for this patient, since he has thrombocytopenia, not because the damage in the brain has already been done. If we're going to treat, we're going to treat to try to preserve his hearing and to try to avoid severe neurodevelopmental outcomes in him. I would give him IV ganciclovir. What I would do in addition is doing screening for immunodeficiency, because we do not want to miss at the same time kids. Their manifestation might be different. So I would do, if we have availability, track screening, I would do immunoglobulins and immunoprofile flow cytometry to rule out primary immunodeficiency. And I would do also HIV screening to rule out secondary immunodeficiency or perinatal transmission. So we can start with IV ganciclovir, follow the blood CMV PCR, and follow the platelet count. And once the PCR has decreased and his thrombocytopenia is better, we can discuss switching to PO valganciclovir with close monitoring, with close early intervention for this child, follow-up hearing assessment closely up until the age of 2 years, and follow-up eye assessment also.
So as per the current recommendations, we would treat for up to 6 months, because studies show that these babies, those who have been treated for a prolonged period, have better outcomes as far as hearing and neurodevelopment is concerned. Current recommendations do mention treatment for up to 6 months with oral ganciclovir.
Yes, I personally sometimes give up until 12 months.
12 months. Okay. Yes. Thank you so much. So I think that was a very exhaustive discussion on CMV, which went right from the antenatal to the postnatal period. And with that, we would thank you, Dr. Rima, for that nice discussion. And we will not discuss the second case of CMV, but we would move on to the third case. This is a 27-year-old primary gravida who on the 22nd week's ultrasound had oligohydramnios, but no fetal abnormalities. But because of this oligohydramnios, undergoes a TOT screening. Now it's controversial whether it should have been done or not, but the toxoplasma IgG was positive and the IgM was also positive. Now, because both of them were positive, an IgG avidity was also done, which was 96%, and acute toxoplasmosis was suspected. Now, my question to Dr. Alejandra is that can you please explain to the viewers about this IgG avidity test? And with this result, would you go ahead and do an amniocentesis to find out whether there is fetal toxoplasmosis or not? And would you treat the mother?
Hello, good day to everyone. It's very nice to be here with you all, and thank you for the invitation. So, the first question about if the IgG ability is useful, yes, that test will tell us how early or how late the infection was. So that will give us the idea of if we have to treat or not treat the mom. In this case, since she has a IgG positive and IgM positive, and the IgG ability test was 96%, this will tell us not the exact time that she was infected, but that it was like more or less. Definitely an amniocentesis should be performed and should be done. It can be done from the 18th week of gestation. And it's important is that it allows us the early diagnosis of infection in the newborn. And since its specificity is close to 100%, in many clinical practices, the PRC aims to confirm a fetal infection in order to decide whether to treat with spiramycin alone or to try pyrimethamine and sulfadiazine. Okay, so that will help us to know which kind of treatment should we install in the mother. And definitely with these results, maybe we should treat the mother.
Yes, so just to add to what you said, even if the IgG avidity is 96%, it could mean that the mother was infected maybe 5 months earlier. And since this pregnancy is 22 weeks, it could mean that the mother was still infected in the first few weeks of pregnancy. So even a high IgG avidity means that she could have been infected in the first couple of weeks, and we should go ahead and do a amniocentesis and check the PCR.
Yes.
So you would
Yes.
do it, and then you would rightly said that we would go ahead and do this, and if the PCR is positive, we would have to treat. And beyond 14 weeks, we could give pyrimethamine sulfadiazine, and if it was earlier than 14 weeks, we could give spiramycin. But unfortunately, in this case, the pregnancy was continued till term. They did not go ahead and do anything, and the baby was delivered, and the baby was underweight, had a petechial rash, did not have any organomegaly, hepatosplenomegaly, or microcephaly. The fundus was normal. Of course, the neonatologist who was looking after the baby was aware that the mother had a positive IgM, so they were looking out for congenital toxo. So they investigated the baby. The baby had polycythemia, maybe because he was an IUGR baby, had leukocytosis, had thrombocytopenia. They sent a toxo PCR in the blood, which was negative. The toxo IgM was positive. The IgG was positive because of transplacental antibodies. The ultrasound of the brain was normal. The baby had proteinuria, had hypoalbuminemia, and the hearing screen was normal. The blood cultures were sent, and they at that time thought that maybe the baby has some kind of sepsis because of this leukocytosis, thrombocytopenia, etc. And the baby also developed respiratory distress. His X-ray was abnormal. Blood cultures came negative. The platelets fell to 40,000, and they did a CT which showed calcifications. So, Dr. Alejandra, is this sepsis-like presentation unusual for congenital toxo, or can it present? Can any of the TORCH infections present with a sepsis-like presentation? Even Dr. Rima said earlier that you can have this kind of presentation. So would you think that this is usual or unusual for congenital toxo? And now, are you convinced that this is all congenital toxo and nothing else? And what regime would you follow in this patient? And let us suppose that this baby was born and the baby was completely asymptomatic. and the only abnormality was that the baby had a positive toxo-IgM, would you still go ahead and treat this baby?
Okay, so yes, definitely with a patient, a newborn patient, and with all the clinical manifestations of a congenital toxoplasmosis, the neonatologist should think first. They have to rule out that the baby doesn't have sepsis, because that is like the primary aim, to control the sepsis. If if he can have both the sepsis and the congenital toxoplasmosis, and most of the time they consult us because they see the patient with low platelets and they think, oh, maybe it's a fungus or maybe it's a gram-negative infection. But after we see that they have all the manifestations of congenital toxoplasmosis, sepsis should be left out of the table, and we should start the treatment for the congenital toxoplasmosis. But that's all the battery of exams that we have to do when we evaluate a congenital infection. And yeah, we should rule out the sepsis, and that's a common, not mistake, but like the way that we should evaluate the patient to rule out the sepsis. And with the other question, what regimen is followed for the treatment of congenital infection, congenital toxoplasmosis? I didn't see if they had a lumbar puncture done to the baby. So how were the proteins and everything? You don't remember?
No, they didn't do a lumbar puncture.
Okay,
But
so
would
that's
would
yeah,
that kind of
that's
change therapy?
well, maybe in that area, if they have like an active or a CSF proteins elevated in the CSF, we should add corticosteroids to the regimen of treatment. Okay, so yeah, definitely we should have done the lumbar puncture. I don't know if the baby was unstable and the lumbar puncture wasn't done, but the regime that we should start would be with sulfadiazine, bumetamine, and folinic acid. And if the baby have the CSF protein elevated or chorioretinitis, we should start with corticosteroids.
Okay.
And usually the treatment is like for around 1 year, 12 months. Yeah.
And what
So
about
I see in the
treatment for, that's an excellent point. And what about treatment for asymptomatic babies? Would you treat asymptomatic babies?
Well, if in this case, for instance, we had the mother that had the amniocentesis positive, right? I would definitely, or just IgM positive. That's the question.
Yes. So suppose the mother didn't have a amniocentesis done and the baby was born and the baby was toxo-IgM positive. Would you have treated this baby if the baby had a completely normal physical examination, normal eye examination, normal CT? Would you have still gone ahead and treated the baby?
So there also, it's very important to have the IgG to know how the patient had, if they, although the IgG will be more of the mother, but maybe in that case, we should follow up the patient to see if it has any other manifestations and see if it should be treated or not.
But if the baby is toxo-IgM positive, then I think it means that the baby is infected. The baby is toxo-IgM because IgM would not have crossed the placenta. So I think in that case, the guidelines do say that for toxo at least, because sometimes the manifestations can come later on and then one would at least err on the side of treatment. I don't know if the other panelists would like to comment on that treatment of babies who are asymptomatic but just toxo-IgM positive. Would you treat or not?
Yeah, I think I would prefer to give treatment to this baby if the baby is even asymptomatic.
Yes, because like CMV, when they can actually manifest later with hearing loss or some other problems, even in toxo, they could, they could manifest later with problems. So even for asymptomatic babies, if they're IgM positive, we would go ahead and probably treat them.
Yeah, in the Red Book, the American Association, they say that if we have an IgM positive, first we have to rule out if it's a recent infection, a chronic or latent infection, or it may be a false positive reaction. So if the timing is very critical, yes, we can start. But first we have to establish if it's an acute versus a chronic infection using additional panel tests such as the IgG ability. In the meanwhile, that we have the
This is the baby that we are talking about, the newborn. The newborn, yeah.
Yes.
The newborn is IgM positive, then I guess we would go ahead. We should reconfirm it once, but then we would go ahead and treat the baby.
Oh, yes.
Yes.
Initially, yes.
Yes. Okay, so then we move to the next case. So this is again, this is a case which is quite common in resource-limited settings of a multigravida who's not tested for HIV in pregnancy, who comes in labor and that time is tested, who's HIV positive. She delivers. It's a underweight male baby. So Dr. Ida, now that we have a situation when you have a woman who's tested positive at the time of labor, so what will be your advice about ART prophylaxis to the baby, breastfeeding, testing the baby for HIV, immunization, and cotrimoxazole prophylaxis in this situation when the mother has not received any ART in the antenatal period?
Oh, yes. Okay. First of all, to all newborns exposed to HIV in perinatally should be given antiretroviral prophylaxis. And the infection of the baby may occur in airway, intrapartum period, or via breast milk. And we should give the antiretroviral prophylaxis as soon as possible and preferably in the first 6 hours of life. And unfortunately, this baby is high risk of HIV transmission from mother to child. So what is the high risk definition? If the mother did not receive any antepartum antiretroviral drugs, if the mother received only intrapartum drugs, or if the mother received antepartum antiviral drugs but did not have viral suppression, which means the viral load is not below the 50 copies per milliliter. These conditions defines the high risk of mother-to-child transmission. So this baby is at high risk for the acquisition of HIV infection. And we should give a presumptive HIV therapy, which means a 3-drug regimen to this baby to protect or to treat HIV infection. And we can administer zidovudin plus 3-TC, lamivudin, and plus nevirapine in treatment dose, or if available, zidovudin plus lamivudin plus raltegravir. And we should administer them together from birth to for 2 to 6 weeks. And if the duration of therapy of this 3-drug regimen is shorter than 6 weeks, we should continue zidovudin prophylaxis at least for 6 weeks. And what about the prophylaxis? Yes, prophylaxis for pneumocystis jirovecii infections with cotrimoxazole should start at between 4 weeks and 6 weeks of age until HIV diagnosis is excluded. And of course, breastfeeding should be stopped if it's possible. And what about the testing? Yes, in this baby, because the baby is high risk for transmission, we should perform diagnostic tests for 5 times. On the first day of life, at the end of 2nd week, at the end of 4th week, at the end of 2nd month, and at the end of 4th month. And if available, we should perform HIV nucleic acid amplification test, including HIV RNA PCR test or HIV DNA PCR test. And what about immunization? Yes, as soon as possible, we should start the immunization schedule of this baby. And HIV-exposed infants and children should receive all vaccines, but we should be careful about especially for 2 vaccines, including BCG vaccine, which is a live bacterial vaccine for tuberculosis, and for the OPV, oral polio vaccines, which is a viral vaccine. And we should not administer these 2 vaccines to HIV-exposed infants until definitely exclusion of HIV diagnosis.
So is that a policy in Turkey? Because in India, we still go ahead and give these vaccines to HIV-exposed babies. Because when these babies receive these vaccines, they're generally not immunocompromised. So I think that policy differs depending on the country where you are, because in India, we still go ahead and give these vaccines.
Yes, country-based recommendations can differ between different regions. But in my country, we usually follow the ACIP recommendations and we did not administer BCG and OPV to HIV-exposed infants.
Dr. Rima, what is it, the policy in Lebanon? What do you do over there?
So in Lebanon, we do not have the BCG vaccine on the immunization schedule because we do not have yet high rates of tuberculosis. So we do not give BCG. And we moved recently from an OPV to an IPV schedule. So we start by, over the last 2 years, we started giving the first 2 doses as IPV. So at 2 months and 4 months. So we have time until we start the OPV, the 6-month OPV. But I was going to ask Dr. Ida, so you said you do 5 PCR tests?
Yes.
Okay. And also in resource constrained area, because PCR is expensive and it's not all the time covered by the government. I sometimes don't do all the testing. So I do the first test at 2 weeks. And then I do subsequently at maybe 4 months or 6 months. And then we do the antibodies after the age of 18 months. Thank you.
Yeah. Dr. Alejandra, what is the policy in Costa Rica? Do you give BCG and OPV to HIV-exposed babies?
So we do have BCG vaccine and we do vaccinate all the population with BCG. But if the patient had the history of being exposed to HIV, we do not put the BCG. And also in Costa Rica, we have IPV, and that's the same as Dr. Rina said. So we do put the IPV.
Okay.
Yes, I should notice that in Turkey, we start with IPV vaccine, and at the end of 6 months, we administer OPV vaccine also. But in these babies, we administer only inactivated polio vaccines.
Okay, thank you. Okay, so we'll go to the second set of cases. So case 5. This is a case when you are the neonatologist on call, when there is a primigravida who's in labor, the membranes have ruptured, and the obstetrician notices genital vesicles typical of HSV. And there is no prior history of vesicles earlier. So how are you going to manage the newborn? Dr. Rima, the question is for you.
Thank you, Dr. Singhal. So this is also a scary question that we get sometimes very rarely from the obstetrician. So seeing genital herpes during delivery. So I'm just going to walk through the way I think about it. So, every pregnant woman who's coming to deliver should be screened for genital herpes by mainly 2 things: asking her if she has any prodromes, like if she has any pain or itching in the genitalia, and looking on physical exam to see if there are any lesions over the external genitalia. And if these are the case, then the recommendations would be to go for C-section instead of vaginal delivery. And there are several recommendations at this point. And some of these recommendations are from the ACOG, from the American College of Gynecologists, and from the Royal College of Obstetricians also. These are the main ones that I usually read and follow. So we have a lady who's primigravida. who I hope she's full term, because that would carry more, that is better than being preterm, and who's having genital vesicles over the suggestive of HSV. So the OBGYN should discuss with the mom at that point, depending on how far she's in the labor, whether he needs to go to vaginal delivery or go to C-section. There are several factors. One of the factors is if she has rupture of membrane and the duration of the rupture of membrane. So if she has rupture of membrane less than 6 hours, also it is recommended to go for C-section instead of NVD. For the question, if she has prolonged rupture of membrane, then there are no clear data that shows there are positive or negative neonatal benefits for going for C-section versus vaginal delivery. But most gynecologists and the recommendations of the ACOG also and of the Royal College is to go ahead and do a C-section, specifically if the genital herpes infection occurred during the 3rd trimester, and in particular during the previous 6 weeks preceding the delivery. So for this lady, I'm not sure what was the decision. Was it to do C-section or NVD?
So I think in this case, because it was quite far advanced, so they just decided to proceed with a normal vaginal delivery.
Okay, so they went for NVD. We know that since she says that this is her primary infection, we know that with primary infection, there is a higher risk for the baby, specifically if the baby is premature, because he wouldn't have had maternal antibodies transferred transplacentally. So if we have this lady who's primary with maybe primary infection or maybe non-primary first episode infection, there is a high risk for the baby. So the recommendations of the AAP are as follow, and what I would do are as follow. So I'm going to open a parenthesis for the OB-GYN also. So what they do for the OB-GYN for the classification of the maternal infection is look at it. Is it a primary infection or is it a primary, non-primary first episode or recurrent infection? And they are based over serology and PCR testing. So primary infection, we have a genital herpes, most likely HSV2 rather than HSV1. This is the statistics. But the serology for both antibodies for HSV1 and 2 are negative. This is primary infection. And then you have the non-primary first episode where you have genital herpes, most likely 2. You do serology and you find discordant antibodies. So if she has genital HSV2 and at the same time she has HSV1 antibodies, this is discordant. So this is non-primary first episode. This is one category where you have a higher risk for the baby. And you have the recurrent genital herpes where you have genital herpes with HSV PCR documented, and you have antibodies that are concordant, so HSV2. So for primary or non-primary first episode, that the woman delivered by NVD, it was too late to do a C-section. What the recommendations for the AAP are to do, of course, swab for PCR to see if this is HSV1 or 2. In addition, if it is available, do maternal antibodies for HSV1 and 2. And what do we do for the baby? So we have the baby. Hopefully, this is a full-term baby. He needs to have first a complete physical exam. And remember that neonatal herpes infection usually do not present early on during the first 1 or 2 days. It presents toward the first week, 1 to 2 weeks, and then it decreases toward the age of 2 months. Unless you have intrauterine herpes infection, which is a very rare entity, where you will have at birth scars and skin lesions in the baby. So first, we do a complete physical exam, including looking at the eyes carefully, looking at the oral mucosa, throat, palate, looking for lesions. If the baby is asymptomatic, so if he's symptomatic, it's a different story. He goes to the NICU and he has all the workup done. If the baby is asymptomatic and we're waiting for the maternal studies, what we do, because this is a high risk situation since she has genital herpes, we do surface cultures from the conjunctiva, nasopharynx, oral mucosa, rectal area for herpes culture, and we do I would do personally also. I think the recommendations also would recommend to do NLP. And what you can do, so you do for the LP, you do blood test, looking at CSF, HSV, PCR, you do blood tests in particular, looking for CBC, looking for liver enzymes, in particular ALT, because this is an indicator also with HSV infection. And then you start acyclovir. And reminder for the audience, for neonatal herpes, we use high dose acyclovir. We use 20 milligram per kilo per dose every 8 hours. Low dose was associated with higher mortality and higher morbidity. Even with this dose, we still see significant morbidity in these infants, in these newborns. So what we do, we start the medication, and then we look to see what was the maternal classification. Was it primary or non-primary? Like we said, most likely this woman did not have recurrent infections. So if the maternal studies show that she has maternal recurrent genital herpes, she has antibodies, then this is reassuring that the antibodies pass to the baby. We look at the result of the baby. If they are negative, then we can discontinue acyclovir. This might take like 2 to 4 days to have the result. And then we have to instruct the parents that there is continuous risk up until more than 2 months, to have close follow-up with the pediatrician, monitor for any signs, even decreased oral intake, even excessive tearing, conjunctival infection. So this is for the recurrent. If the mom has, if this is documented that this is a primary infection like this lady, we look for the result of the baby. If all results are negative and the baby continues to be asymptomatic, the recommendation is to do preemptive treatment for 10 days, even if it is negative. If the baby is symptomatic or any of the tests turns out negative, then we see what is the classification of the neonatal herpes infection in this child. And as you know, there are 3 classifications. Either we are dealing with skin, eye, and mucous and mouth, which we call SEM, or disseminated or CNS infection. For CNS and disseminated, we treat for 21 days. For SEM, we treat for 14 days. Now, for CNS, we need to repeat the LP to document like a negative CSF HSV PCR before the end of treatment. And if it turns out positive, we prolong treatment by 1 week and we continue repeating. And then if the baby turns out to have symptoms, remember that the current recommendations are to do suppressive treatment with PO acyclovir low dose for around 6 months.
Yes. Thank you so much. So I think that is a very important point, that is why that algorithm is, which is this, that you, in fact, you even have to, sometimes these mothers have to be put on suppressive acyclovir if they have it earlier in pregnancy till the time of delivery. And you have to do these. And I think important thing is that is the only benefit of the HSV antibody testing, because many times these torch testing is sent and there is no other logic of doing the HSV antibodies in the torch test. The only benefit is to classify an episode of herpes, whether it is primary or non-primary. That is the only benefit of the HSV antibodies in the torch test. So I think I would like to, we had this case of syphilis, but I would want to ask, I mean, I think we are short of time, so we will have to discuss 6 instead of the 9 cases that we had. So I wanted to put this question across to Dr. Alejandra, because, you know, this is particularly important in today's times about Zika. So this is a situation which we faced here in India, and Zika is new to India, and we were in a tight situation about counseling this 35-year-old primary gravida who had conceived by IVF. And she was 6 weeks pregnant and she had an acute febrile illness. Her dengue and chikungunya PCRs were negative, and then she tested positive for Zika. And these are very few cases of Zika in India. And so, Dr. Alejandra, how do you counsel a mother? You know, it is a precious pregnancy. So how do you counsel her? And how would you, about the risk to the baby, how would you follow up in pregnancy, and how would you counsel her about termination, etc.? So this question, because I know this is a problem in Costa Rica.
Yes, so previously when all the cases appeared in Brazil and also in Costa Rica, we had like a lot of cases of Zika in Costa Rica. So first we have to tell the mother that only 20 to 30% of the fetuses and neonates will have the infection, okay? And of those, 4 to 7% will have a fetal loss, and of those 5 to 14% will have the congenital Zika syndrome. Of those, 4 to 6% will have microcephaly. And the other group of patients will be asymptomatic. And only, 70 to 80% of the fetuses and neonates are going to be born without the infection. The other thing to note is that, yeah, definitely seeing a baby with a congenital Zika syndrome, it's very painful. And not only if they have microcephaly and they don't manifest early in the early ages, most of them, or they will have like medium to long-term sequelae when they are bigger, like neurodevelopment delay and everything. So it's very difficult to assess a mother and tell them if they have to terminate their pregnancy but we have to tell them everything. Here in Costa Rica, it's illegal to terminate pregnancies, even though if the baby is known to have a disease. So first we have to tell them what's the chances they have of getting the infection, that it's a very high probability they will have it. Yeah.
So, so would the 16 weeks ultrasound tell us for sure whether the baby is going to be safe or going to be infected? I mean, is there any way to predict that the baby is going to be normal or not?
There's no way to predict if the baby is going to be normal, but in the studies and the patients that we saw, if the infection was in the first trimester, it's more probable that they will have the congenital manifestations. But there's no test that can be done in uterus to know if the baby is going to be infected or not.
So, would you normally, like, how do you normally follow up these women? Like, would you do a amniocentesis at 16 to 18 weeks and do a PCR, or would you just follow them up with ultrasounds?
We will follow them with ultrasounds, and as soon as the baby is born, the baby here in Costa Rica, they are referred to, we have done the PCR in the babies when they are born, and we follow them in the congenital clinical infections clinics.
Just to ask, are there a lot of women who opt for medical termination of pregnancy if they are diagnosed to have Zika in their first trimester?
So, as I said, in Costa Rica, that's illegal. So they have to follow the pregnancy.
Oh, okay.
Mm-hmm.
So they cannot. Okay.
No, legally they cannot.
They cannot. So they have to continue. So
yes.
Because in this case, in this patient of ours, which we had, because she chose to go for medical termination of pregnancy, because I mean, they just go on the net and they read, and the risk of microcephaly is, I think, 4 to 6%, but she did not choose to accept that risk. So,
and definitely when you see a baby born with the congenital Zika, they are very irritable. They have a lot of pain, so it's very hard to see those babies. But also, in the other hand, we say that only like 4 to 6% they are going to have the microcephaly, so it's very difficult to take a decision for the mom.
I was reading that the sensitivity of the ultrasound to pick up a baby with neurological abnormalities about 60 to 70%. So there will be babies who will have normal ultrasound examination, but when they are born, they will they may have abnormalities. The MRI may be more reliable. Do any of the other panelists have anything to add here? or Zika.
Yeah, and something very important that there's not only the microcephaly, they have eye abnormalities and they have development abnormalities. So if you see a baby you have a PCR that's positive for Zika, you have to follow them because like in the first 2 years, you're going to see all the manifestations, all the other manifestations, not just microcephaly.
Thank you. So I think with that, we are going to go to the last case, and this I would like to ask Dr. Ida. So we have this 24-year-old primary gravida who has recently delivered a term neonate, weighing 3 kg 1 month ago. She's coughing, has fever for 2 weeks. The chest X-ray shows cavitary consolidation. The sputum is smear positive for AFB. And the gene expert shows RIF resistance. I don't know how much of a problem is drug-resistant TB in Turkey, but it's a big problem here in Mumbai and in India. And there is INH resistance, but no quinolone resistance. So we are dealing with a baby born to a mother with MDR tuberculosis. So now the question to you, Dr. Ida, is that what will be your advice regarding separation of this baby from the mother, evaluation of the baby, breastfeeding, and chemoprophylaxis?
Yeah, thank you. Yes, especially in some states in Turkey, drug-resistant tuberculosis can be seen, especially from refugees from other countries in this population. So it's a problem in Turkey also. And this mother should be managed as a pulmonary tuberculosis, first of all. And there are 3 possibilities for the baby. The baby maybe became infected during the intrauterine period, and the baby may develop congenital tuberculosis, or became infected through respiratory contact during the postpartum period by airborne transmission, or the baby is not infected. And this is the good option. And in order to distinguish these conditions, a detailed evaluation, including physical examination, chest X-ray, tuberculin skin test, fasting, gastric fluid sampling, and in some cases, lumbar puncture may be required. And theoretically, first 2 weeks after initiation of anti-tuberculosis therapy, the mother can be considered as contagious. For these 2 weeks, in families with, of course, appropriate social conditions, the baby and the mother temporarily should be separated. However, the mother's expressed milk can be given to the baby during this period. And in families where conditions are not suitable, the mother and baby can stay together. And it is recommended that the mother continue to breastfeed her baby by wearing a surgical mask. In low-income settings, infants are rarely separated from their mothers after birth, even if the mother are known still contagious. So establishing breastfeeding and bonding with the newborn infant is important. And care for the infant includes advice on infection prevention and control measures, including wearing a mask when handling baby or feeding the infant until the mother is on effective therapy for at least 2 weeks and or sputum smear is negative. And the sleeping in separated rooms and allowing the ventilation of home and adhering to mother's own treatment and infants' prophylactic treatment. And temporarily separating infants from infectious mothers until they are non-infectious or non-contagious may be indicated in mothers with multi-drug resistant tuberculosis, pre-XDR tuberculosis, or XDR tuberculosis if no prophylaxis options are available. However, this is only possible if an alternative reliable caregiver is available. And WHO recommends using tuberculosis prevention therapy for contacts exposed to people with multi-drug resistant tuberculosis, following consideration of the intensity of exposure, confirming the source patient and their drug-resistant pattern, and confirming the TB infection using IGRA or tuberculin skin test. Very possible, of course. And WHO also suggests the use of levofloxacin for 6 months, along with other TB drugs, including ethambutol or ethionamide also. And regardless of whether treatment is given or not, clinical follow-up very important for these babies. And we should follow these babies at least for 2 years closely.
Yes, so I think that's an important point, that if the mother has drug-sensitive TB, then separation is not so important. But if the mother has drug-resistant TB, then separation is important, and evaluation of the baby to rule out disease is very important before starting chemoprophylaxis.
Yeah.
So I think we had thought of discussing 9 cases, but we were able to discuss 6, and I think there are a lot of questions on the chat. So shall we discuss the chat questions now? What do the panelists say? Shall we go ahead and discuss the chat questions?
Of course, if you want.
Yes.
Yes, yes. Mm-hmm.
Okay. So, Doctor, I mean, shall I take up the chat questions, or will Dr.
Yeah,
Abhay?
can you please stop sharing the slides so that we can have
Okay.
a common platform?
Yes, yes.
Yeah, so we start the questions.
Okay. Okay. So, shall I start the questions?
Yeah,
Yes,
please.
Okay. The first question is, when we suspect neonate had congenital CMV, and when we should treat congenital CMV and the treatment. So I think this has already been answered by Dr. Rima, that the manifestations of congenital CMV include, hepatitis, hepatosplenomegaly, rash, calcifications, periventricular calcifications, and she has already discussed the, treatment and
Window.
also the indications for treatment.
Yeah.
Then there is a question, in places where there is a challenge in lab diagnosis, is there a place for chemoprophylaxis? I'm not very sure whether I understand this question. Does anybody understand the question?
No, it's a wide
I
question.
think it implies more to tuberculosis rather than any other
Right.
infection.
Yeah, so I think they may mean that whether, if you don't have availability of an IGRA or a tuberculin skin test, can you go ahead and do chemoprophylaxis? I don't know whether it means that. We can do that. I mean, you don't need, in babies less than 5 years, you don't need to prove latent TB infection. You can go ahead and do that, but you surely have to rule out active TB disease. There's a question, in resource-limited settings when there is no PCR test, how can we use serology to support diagnosis of congenital CMV infection in neonates? Maybe Dr. Rima, could you take up this question?
Yes, well, this is a tough question also because we're used to using PCR. So you can look at the clinical picture of the infant, of the neonate, and then check CMV, IgG, and IgM. And remember that CMV, IgM early on will reflect maternally transferred transplacentary antibodies. Well, the CMV, IgM, although it might be negative early on, so it doesn't rule in or out congenital CMV infection. If you have positive CMV IgM, then it is reliable and you can go ahead and treat. Now, the follow-up is going to be tough because CMV IgM tend to stay for a long period of time, for several months, so you wouldn't know how to gauge the medication. or how to stop the medication. And remember also that if you're going to use serology, you need to screen for severe combined immunodeficiency, specifically in areas in developing countries where we have high rates sometimes of SCID, of severe combined immunodeficiency. So you don't want to run into a patient where they have SCID, where they have a higher risk of CMV infection, and you're following IgM, where they do not produce enough IgM.
I also wanted to add that the sensitivity of CMV IgM is quite low. And the other point is that now CMV PCR is available quite widely. So you could opt to send out the test because CMV is difficult illness to treat. So you could opt to send the test out. That would be a... And another point I wanted to make is that the diagnosis of CMV should be established in the first 3 weeks of life. Because beyond that, if you have a CMV IgM or a PCR positive, it could mean postnatal acquisition of CMV. There is another question, Dr. Alejandra. Is there any alternative drug option for toxoplasma if pyrimethamine sulfadiazine is not available?
Yes, it's like a second kind of drug, and you can use trimethoprim sulfa if you don't have the sulfadiazine. Yes.
So there is data for ocular toxoplasmosis for trimethoprim sulfamethoxazole, but has it been used for congenital toxoplasmosis also?
If you don't have that, the other kind of drugs available, I think
You can
our
use
recommendation would be to treat them with those.
treat them
Yeah.
with that. Okay. I think there is some data about azithromycin, but I think it's very scanty. But that is also
Yeah, it's very
which
scanty.
has been used.
Mm-hmm.
There is a question, maybe any of you could take it, Dr. Ida. Is it recommended to screen for torch infection during neonatal period? I mean, would you recommend a blanket screen for torch?
If the baby has no any problem, there is no any physical finding or laboratory abnormality, we do not screen all babies for torch infection. It's not rational, and I think this is a worldwide approach. And of course, high-risk pregnancies, or if the baby has a sign of a congenital infection, then we start to screening of torch infection in neonates.
Yes, so I think screening may lead to a lot of false positive tests and a lot of confusion. It would like being opening a Pandora's box. So there is a question, Dr. Alejandra. If the fetal brain has large calcifications due to toxoplasma, should I need to consider preterm delivery?
I don't understand that question.
So I think this is about a baby who has been, a lady who has been diagnosed to have toxoplasmosis, and the fetus also has toxoplasmosis.
Uh-huh.
So I don't know, you would be treating the mother anyhow with pyrimethamine sulfadiazine. So I think the question is that would you probably deliver the mother early so that you can treat the baby effectively? I think that would be the question.
No. Yes, I wouldn't deliver the baby premature. It would be like more danger for the baby if it would have like other abnormalities. Yeah.
Yes.
Uh-huh.
So the question is, at what trimester should the pregnant woman be tested for torch infections antenatally? I don't think you would test the woman like that. You would test only if she has a problem. There is no recommendation to routinely test women for torch infections. In fact, it would cause more problems. I think there are only certain countries like France which test for toxoplasma routinely. I think the recommendation is only to test for hepatitis B, HIV, and syphilis routinely in all pregnant women. Those would be the 3 tests to do, and you should be doing them in the first trimester. And for high-risk women, you would test them again in the 3rd trimester.
And here in the prenatal, if a woman is planning to have a pregnancy, well, definitely we should recommend that in the previous test before they get pregnant, they should have like a torch exams done. That would be like easier, not when they are pregnant.
Absolutely, yes.
Mhm. Mhm.
Then there is a question, what if we don't have any CMV PCR tests in our hospital when anti-CMV IgM result is negative and IgG result is positive for small for gestational age neonates without any other findings for torch infection? So the question maybe, Dr. Rima, is that only the baby's IUGR and there is no other manifestation of CMV. Can CMV present with just IUGR and nothing else? You are muted. You are muted.
Please unmute yourself, Dr. Rima.
So, thank you. So it could present with only IUGR. The important part is, as we mentioned earlier, during the first 3 weeks of life to rule out congenital CMV, I would definitely send the child for hearing assessment, ophthalmo assessment, take blood tests for liver enzymes and for CBC, and try to do blood for CMV PCR. Try to send it out maybe during the first 3 weeks.
There's a question, if the neonate still tests positive for CMV PCR after 6 months of Valgan cyclovir, how long should we treat such babies?
Well, that's an interesting question. I personally tend not to follow CMV PCR because, you know, CMV is a latent virus. It tends to reactivate. So you might have intermittent CMV viremia. In a child who has life-threatening CMV and congenital CMV infection, in the case you find persistently high CMV viral load, I would do 2 things. I would try to rule out immunodeficiency, whether primary or secondary from HIV. And if I have been treating correctly, I would try to make sure there is no CMV resistance. In a child who is really sick, who has life-threatening congenital CMV, and specifically if they have immunodeficiency.
So I also feel that low-grade CMV viremia is normal in normal people. You can have CMV viral load of 400,000 in normal people. So I don't think we should aim for undetectable CMV viral loads in such patients.
Usually, even the guidelines recommend to continue checking CMV PCR. I personally, in my practice, stop checking it.
Yes. In fact, in my CMV, congenital CMV patients, I shift them all to oral Valgan cyclovir after 6 weeks, and I don't repeat a CMV PCR in these patients at all.
Unless they are immunocompromised.
Yes, unless they're immunocompromised. There is a question, is there any molecular test for toxoplasma like PCR? I think there is a test for toxoplasma. There is a PCR available. Dr.
Yes,
Allen,
there is a
yeah.
Yes, there's a PCR available. It's not available in all the countries. We don't have it here in Costa Rica. So what we use is the serology and the ability test. Yeah. Sometimes for transplant patients, we do have the viral like more tests, but for congenital we only have those.
There's a question, in CMV infection during treatment, how often should we monitor the baby, and are there any prognosticating markers?
So in terms of follow-up, you know, Valgan cyclovir can cause bone marrow suppression. And in the initial studies where they used IV ganciclovir, then PO valganciclovir, sometimes they used to give Neupogen, GCSF, just to make sure the white blood cells are not very low. So what I do is I follow maybe every couple of weeks and then monthly blood for CBC to look at white blood cells, hemoglobin, hematocrit, platelets, and I look at kidney function and liver enzymes. Most often, kids tolerate it for 6 months. Very few cases would have mild pancytopenia, where I've had in a couple of occasions had to use GCSF, where I needed to treat to make sure the white count is better, or you can drop the medication for a couple of weeks and then restart. Any prognosticating markers? I'm not sure about that question, but usually, so for congenital CMV infection, the main problem is to the main aim of treatment is to prevent hearing loss and to make sure the hearing is stable once we get over the life-threatening conditions early in the first few weeks, like we get over the hepatosplenomegaly, the pneumonitis, the meningoencephalitis. So we need to make sure they have stable hearing and they are neurodevelopmentally okay. So what we do, we continue to have follow up with the ENT team with hearing assessment and follow up with a neurology team also, even if their initial neuro exam is normal, and we send them to the developmental clinic for early intervention.
Dr. Ida, there is a comment about how in HIV-infected mothers, we should not be stopping breastfeeding. I think you are reading it, because there is a dichotomy, because the WHO says that, HIV mothers should be allowed to breastfeed because the risk of the baby dying is higher with formula feeding. So I think that depends on the socioeconomic status. And we were discussing that particular case where the mother had high viral loads. She was not on ART. So your comments on that comment.
Yeah, actually, I was waiting for this question because nowadays it's a common problem. I think we try to keep breastfeeding and its beneficial effects on neonates, and in the same time, we try to keep the baby HIV negative. But the recommendations I think, will change in recent years, following years. And in my country, at least, we usually prefer to stop breastfeeding. But of course, the counseling with the family, with parents, is very important. And we should tell them all the risks for the HIV acquisition and the probability of antiretroviral prophylaxis at the same time with breastfeeding, and this can be a preventive measure for the baby. And I think this depends on our discussions result with the families.
Yes, so I think recently the American Academy of Pediatrics has revised its guidelines. They have said that now if the mother has unsuppressed viral load, she can breastfeed her baby. They have changed their guidelines. But in the situation where the mother has not been on any ART, you have to discuss with the mother. And then I just want to talk about this lady we had in our hospital. She has suppressed viral loads. She gave birth. And then I went to her and said that, please breastfeed your child. And she said, no, I don't want to breastfeed my child.
Yeah.
So I think it has to be a shared decision between the mother and the baby. So mother and the family and this about the breastfeeding. Yes. Okay. So there is a question, and maybe Dr. Alejandra, you can take this. Torch serology done in antenatal mothers routinely. Any guidelines? I mean, you must be getting referrals about mothers coming with torch testing, and how do you handle that? Do you get any referrals?
So in the national system, like the public system, for mothers, they don't do antenatal torch tests, but in the private practice, it's highly recommended. So for instance, if we have a mother that is IgG and IgM negative for toxo, we should do more education and tell all the prevention measures for the mother. And also, for instance, if we have a mother that they have a recent CMV infection, so we will tell the mother to try to delay getting pregnant in these weeks. So I think it should be a practice done in every woman that if they are planning to have a baby, they should have the torch test. That would be much easier. We will prevent further infections. But in the public practice, it's not done. Yes.
So there is a question about saying that sulfadiazine is not available in India, only combination drug is available, how to manage. So I just wanted to tell the viewer that sulfadiazine is available from Jolly Healthcare, so they can reach out to them. There was another question which says, which was saying that CMV infection in the antenatal period is frequently asymptomatic and pregnant women do not show any symptoms or signs. Therefore, how should we suspect CMV infection in the newborn? So I think that is a paradox, that most of the times when the torch testing in the mother is abnormal, the baby is asymptomatic. And the other paradox is that most of the time when the baby has a torch infection, the mother had no symptoms at all. So that is the paradox that we are living with.
Yes, correct.
Yes. So Dr. Reema, what was how would you answer that question?
So, CMV screening in pregnant women is a big question mark. There is one European study where they recommended, I forgot which country, they recommended to do CMV serology for all pregnant women. And if she is CMV negative, then to follow every few weeks. But this is also controversial because, as we discussed earlier, most congenital CMV infection come from moms who have reactivation of their CMV, not from the primary CMV. Although primary CMV might cause severe infection early on during the first trimester, but if you look at the pool of congenital CMV, they come from mothers who have recurrent CMV or reactivation of CMV. So it's really tough for me. The role of doing screening for CMV in pregnant women is a little bit vague at this point. What we encounter sometimes is a young lady or a pregnant woman who has infectious mononucleosis symptoms and who get tested and who test positive for CMV, and then we go and discuss treatment with valacyclovir or immunoglobulins, most likely with valacyclovir. So most of the time, screening in pregnant women, I'm not sure, like from my reading, neither the ACOG nor the Royal College of Obstetrician in the UK recommends screening for CMV unless you catch them from an infection.
So quickly, I think we have 3 minutes and there are no more questions. So a question to you, Dr. Ida, because we had these cases. So a quick question to you is about hepatitis B prevention. That apart from giving hepatitis B immunoglobulin and hepatitis B vaccine to babies born to hepatitis B positive mothers, what else can be done to prevent hepatitis B transmission?
Oh, yeah. In recent years, there are some data supporting the antiviral prophylaxis during the pregnancy with the mothers with high viral load with tenofovir can be preventive for the baby for the decreasing the risk of mother-to-child transmission.
And Dr. Alejandra, do you see congenital syphilis now in your country? Are you seeing increasing number of cases? Because I think there is data coming worldwide, especially from the US, that there is an increase in prevalence of congenital syphilis.
Yes, sadly, we have been seeing an increase in syphilis in our country. So here the importance of performing the non-treponemal tests early in pregnancy and follow them closely to prevent the further manifestations. But yes, and sadly, we've seen an increase in those in syphilis.
So when suppose you have a baby who is born to a mother who had been tested for syphilis and she was treated also for syphilis in pregnancy, you still would go ahead and evaluate these babies and do their tests and treat them if necessary, isn't it? Would you? Even if the mother has been tested and treated, you would still go and evaluate the baby.
Because you don't know if anytime we will evaluate the baby with for instance, with the VDRL, the non-treponemal test,
And if the baby is negative, so we'll be just like normal follow-up of the baby. But if the titers are up or fourfold, we should definitely study the baby.
And do you get penicillin G easily in your country to treat these babies?
Yes.
Penicillin G, procaine, penicillin.
Yes, that's the treatment for the babies with syphilis, and we get it very easily.
And the last question to you, Dr. Rima, because we had a case of a 2-week-old baby getting exposed to chickenpox from his mother. So the question to you is that we know that if the baby gets exposed to chickenpox, when the mother has chickenpox 5 days before and 2 days after delivery, we give the baby Vizig. But for a 2-week baby, would you consider giving Vizig?
So depending if the baby is premature or no, we know that in
It's a
premature,
term baby.
full-term baby. So if we have a full-term baby whose mom developed primary varicella infection, so chickenpox, as you mentioned, if it is before 5 days or after 2 days around delivery, up to 7 days after delivery, the recommendations is to give the baby varicella zoster immunoglobulin, or if it is not available, IVIG. Now, if the baby is more than 2 weeks or at 2 weeks, we know that most neonatal varicella infection are relatively mild after the age of 2 weeks. They might have some complications, but I wouldn't give him varicella zoster immunoglobulin. We would monitor him closely to see if he's going to develop chickenpox. And then if he has severe varicella infection or any concern, we'll admit for IV acyclovir.
Thank you.
And for VZV, the IV acyclovir is lower than the dose for HSV. So it's 10 per kilo per dose Q8.
Yeah.
Thank you. So I think
So,
we are in time now, and I think it was a wonderful discussion with all of you, and we managed to cover all the cases. So the last 3 were done briefly, and I think there was thank you all so much. And I think we were able to give the basic messages that we need to understand that this is a topic in itself, torch infections, and they are challenging to diagnose, treat, and we do need a lot of resources, especially in terms of molecular tests to diagnose these. And I feel that these are not common infections that you see every day. So even if you are faced with a case, and even if these tests are not available to you, you can actually try and make efforts to send out these tests, because you are not going to be seeing these cases every month, or you may be seeing these cases once in 6 months. So probably send out these cases, and we can seek help of all the experts, in managing these cases, and trying to give the best that we can, so that we achieve good neurodevelopmental outcomes for these patients. Thank you so much.
Yeah. So thank you so much. It was a
Thank you very
wonderful
much.
discussion. And all the cases were very spectacular. And it was a wonderful discussion. And almost all the spectrum of the disease cases have been covered. So I'm sure that viewers will be benefited at large. So thank you for this wonderful panel discussion, Dr. Tanu. Wonderful cases and very informative inputs from all the experts. And thank you very much to all the viewers as well. So now you are taking off. Yeah. Over to IP office. Yeah. Hello. Hello, admin.
I think you can only sign off, Dr. Abhay.
Okay, so we are leaving it. Okay, bye.
Bye.
Everybody, bye. Yeah.
Bye.
Bye. Thank
Bye.
you, everybody.
Bye.
Nice
Bye.
to meet you.
Bye.
Good evening
Yeah.
Bye.
and good
Bye.
days.
Thank you very much. Have a good night.
Good night.
Thank you.